Hi, this is Alicia Bright again. We're going to be talking about the concept of cognition as it applies to stroke patients. I've broken the stroke lecture into two parts. Part one, we're going to talk about general introduction to stroke, reviewing what it is, etc. And in part two, we're going to talk about the experience of the stroke patient, what kinds of disabilities you can have, and nursing care for those things. So, stroke is the fourth leading cause of death in the United States. It's a leading cause of serious long-term disability in adults. About 600,000 cases of stroke happen every year. About 140,000 deaths related to strokes happen yearly. So that's quite a significant number of people who have strokes die from them. People who do survive, about 50 to 70% of them regain functional independence. That means they don't necessarily recover completely, but they're independent. But about 15 to 30% are permanently disabled. The length of time it takes to recover depends on how much brain tissue is involved and damaged, and where that brain tissue is, what kind of disability is incurred. So remember that a stroke is a sudden decrease in blood flow to a local area of the brain that results in neurological deficits. There are two kinds of stroke. Basically, it's either ischemic or hemorrhagic. Ischemic, not enough blood flow. It can be a clot that travels through the body to the brain, or it could be a clot that happens in the brain. Or it could be hemorrhagic, a bleed. And in that case, it's generally classified as to where it is. Intracerebral hemorrhage would mean a bleed down inside the brain. A subarachnoid hemorrhage is a bleed on the surface of the brain, just underneath the arachnoid membrane. You remember there's the dura mater, the pia mater, and the arachnoid. Those are the membranes between the brain and the skull that we know of in the past. Basically, we want to prevent them. So, preventing strokes, this is going to look familiar. How do we take care of ourselves? Healthy diet, weight control, regular exercise, no smoking, limited alcohol consumption, and routine health assessments to manage those medical problems that we discussed in the previous slide. So, medications that we can use. We actually have some medical prevention strategies. Medications that we can use include antiplatelet drugs. If people have had TIA related to atherosclerosis, they might give Plavix. That's one of the more common antiplatelet drugs. For years now, they have recommended that people take a baby aspirin every day to make the platelets slip by each other more easily and not clot. That actually has come into question in the last couple of years. There was a large study that suggested that the side effects from the aspirin, the downsides may outweigh the benefit in terms of stroke prevention. So that's not as strongly recommended as it used to be. In fact, a lot of people are recommending against it now. People with atrial fibrillation are at high risk for clots, so we'll anticoagulate them with Coumadin. Of course, controlling atrial fibrillation, if at all possible, is how they do it. But people with chronic AFib are on Coumadin or some other kind of blood thinner. There are new blood thinners available. Coumadin is easily reversed with vitamin K. Some of these new blood thinners are not easily reversed with vitamin K. So, risks and benefits have to be weighed. Statin medications are also used to prevent stroke because they prevent plaque buildup. So I want to differentiate between a stroke and a transient ischemic attack, or TIA. So a TIA is associated with an increased risk of stroke, but it is not a stroke. What it is a transient episode, so 1 hour or less, transient episode of neurologic dysfunction caused by a focal brain, spinal cord, or retinal tissue ischemia but without acute infarction of the brain. So ischemia, you remember, means lack of blood flow. Infarction means death of tissue. TIAs are temporary. They can progress to a stroke, but typically it feels like a mild stroke, or it looks like a mild stroke, but it resolves within an hour. However, a lot of people will progress to having a stroke. Now, there's an excellent case study on Elsevier that goes through the experience of a patient who comes in with TIA and then comes back again having had a stroke. That's an excellent case study. Work your way through it on Elsevier. The other thing I'm going to recommend is the video on the reporter having a stroke on camera. She actually doesn't have a stroke. It's a TIA, and it's caused by a particular form of migraine. You don't hear that during the video itself, but the video is a cut of her as she was about to give a news announcement, and suddenly she can't speak right. It's a fascinating video. Watch her face. It goes very, very quick, maybe 15-20 seconds. But you watch her face, because she realizes that suddenly she doesn't know what she's saying. But that is an example of a TIA. That woman turns out to be okay, and there's a wonderful interview describing her experience of having gone through that and what it was like for her and her coworkers. All right, let's go back to talking about strokes. Thrombotic strokes or thrombolytic strokes versus hemorrhagic strokes. A clot cutting off circulation to a portion of a brain versus a bleed. The blood builds up and puts pressure on the surrounding tissue. Treatment of these are going to be very different, but the effects of on the patient's ability to function are basically the same. So the medical treatment is different. The nursing care is going to be very similar, other than the medications or surgery. So if people have TIAs, or even hopefully before they do, things that we might do surgically to prevent a clot problem would be a carotid endarterectomy, or placement of a stent, or transluminal angioplasty, or extracranial intracranial bypass. That one's been kind of discredited. That's very, very rare, and don't worry about that one so much. Carotid endarterectomy we'll talk about in a minute. A stent is a placement of a tube to keep the artery open. And a transluminal angioplasty, that's where they go in through a large artery in the groin and put a fiber optic tube up until they can repair or remove a clot, or either remove a clot or stretch out the blood vessel there. Carotid endarterectomy. So this is the big artery in the neck. They just go in there, they open up the artery, they bypass it to keep the circulation going to the brain. They clean out the plaque, and then they stitch it back up again. People end up with a scar on their neck, and sometimes they'll put in a little clot catcher to keep clots from going up into the brain. But this is done actually to prevent strokes, particularly for somebody who's had a TIA. So symptoms of a stroke include sudden numbness or weakness of face, arm, or leg, especially on one side of the body, difficulty speaking or understanding speech, sudden onset of confusion, sudden and significant vision changes in one or both eyes, difficulty walking or keeping your balance, or somebody suddenly very dizzy, or a sudden severe headache with no known cause. Whenever this happens, just call 911. Get it started. Time is tissue. Time is tissue. That's the motto for somebody with a stroke or an MI. A fast way to assess people is using this acronym FAST, F-A-S-T. So face, ask them to smile. Does one side of the face droop? If so, call 911. Arms, hold them out in front. If one of the arms tends to drift, call 911. And speech, do they have slurred speech? Can they repeat what you're asking them to say? This is a way of knowing if their language centers are processing properly. If there are any problems with any of those, call 911. Time is tissue. Collaborative care, the goals for any collaborative care during any stroke are to preserve life, to prevent further brain damage, and to reduce disability as much as possible. This is why we need to know what time the stroke starts. So if you're assessing somebody, you want to know exactly the time when symptoms began, because if you get treatment in there within the first few hours, you can actually restore circulation to the brain sometimes. There's a treatment called TPA, recombinant tissue plasminogen activator. This is used to reestablish blood flow through a blocked artery. What that does is, of course, restores circulation to the tissue and prevents cell death. But it has to happen quickly, within 3 to 4.5 hours after the onset of clinical signs of ischemic stroke. So this is when you're in the hospital. You'll sometimes hear announced overhead, we have a stroke code, ETA, 15 minutes. What that means is they've heard from an ambulance of somebody coming in with symptoms of a stroke, and what they're doing is alerting the hospital to the presence of this person. As soon as the person hits the door, they're going to draw blood and get the patient in for a CT or an MRI as fast as possible. That will help them determine what kind of stroke this is, so that they can start treatment. And the treatment for hemorrhagic and thrombotic stroke are going to be very different. TPA you would use to clear a clot. The problem is it's going to clear any clot in the person's body. So when you give the TPA, it will not only get in there and clean out the clot that we're trying to get rid of in the brain, it also busts loose any other clots in their body. So if you've just drawn blood, and you put a nice little Band-Aid and a pressure dressing on their arm, and you give TPA, the clot that had formed there might come loose and they start bleeding again. If they have a GI bleed, if they have any small bit of bleeding that's clotted over in their gut, for instance, a GI bleed, and you give them this clot busting medication, it could bust the clot and start up a GI bleed again. So we want to be very careful giving this. It is controversial, actually, but some people have had benefit from it. Okay, a Mercy retriever. You have to have interventional radiology for this. So you have to have a unit that can go in through that, under fluoroscopy, through that big artery in the groin. They snake the catheter up, and they retrieve the clot and pull it back out. There's a video that I have posted on Moodle. Take a look at it. It goes very quick. It's about 1 minute, and it just shows how this tube's up in the brain, and it just grabs that clot and pulls it right out. Pretty cool. By the way, if you ever have a chance to observe an interventional radiology, it's a great experience. You get to see pictures of what's going on inside the body. Very cool. All right. Collaborative care for hemorrhagic stroke. This is going to be very different. People with hemorrhagic strokes, we need to get them into the OR as quickly as possible. If it's an aneurysm, we'll clip the aneurysm. If there's a hematoma, we can pull out the hematoma. They might need to resect. Hopefully you don't have to resect too much of the brain, but they might need to get in there and stop the bleeding. Collaborative care for somebody with a hemorrhagic stroke. These folks need to avoid anticoagulants, need to avoid platelet inhibitors. So if you gave one of these people a dose of TPA, you could kill them dead. Bad idea. So we need to differentiate what kind of stroke they have as soon as they hit the door. Seizure prophylaxis is very situation specific, so we may or may not need to do seizure prophylaxis. But in the acute stage, they want to manage hypertension. don't worry about this too much right now. You're going to get a lot more about this in MedSurg 3. This is a critical care issue. Just know the difference between a hemorrhagic and a clot. So the goals basically are the same. We want to manage the airway, breathing, circulation, and the intracranial pressure. Prevent long-term disability if at all possible. We might use a GDC coil up inside an aneurysm if it's an aneurysm. That's just a little tiny coil that sits in the aneurysm and keeps it from ever blowing. We might clip an aneurysm. So once somebody has a metal clip on an aneurysm, they can't have an MRI. That's it. MRI would move that little clip around. If you've ever signed a consent for an MRI, it's magnetic resonance imaging. It's got a big, hard, strong magnet in there, and it can attract metal very, very strongly. So the clinical manifestations of a stroke are going to depend on what location got hit, what area of the brain got damaged. It can have physical, cognitive, and emotional impact on the patient. And remember, there's a whole family around this patient that is going to be impacted somehow. It's kind of terrifying to have a stroke, and it's terrifying to have a family member have a stroke. Mobility can be impaired, respiratory function can be impaired, swallowing, speech, gag reflex, and the ability of somebody to take care of themselves. So remember that time lost is brain lost. So if you see someone, and I actually had a student who left my class and within a month actually found somebody who was having a stroke, assessed them, and called 911. So this too can happen to you. Get them in for treatment as soon as possible. And so in the next lecture, we're going to talk more about what kind of disabilities people can develop.